cannot have been asked not to take aspects like patient-centred healthcare or patient choice at face value, but to interrogate them in the 8 minutes that they're going to have to introduce their views to you.
The NHS has a language of its own. It takes its customers, patients, a long time to become fluent and be treated as an equal by clinicians and other staff. That is one of the biggest hurdles patients have to cope with. In addition to being sick, scared and very vulnerable, especially if they are elderly, disabled in any way, or do not have English as a first language, they must try to understand what is being said to them. Empowerment is constantly used day in, day out in the NHS, but what does it really mean? The dictionary says it means enable, permit, or invest with power. It is a very unattractive, almost jargon word for something that is essential to patients being in the driving seat of their care. Without the information that empowers a patient, that patient is not giving informed consent to their care. So empowerment is not just a frilly add-on to the interaction between patient and clinician, customer and supplier. It is the basis on which the NHS does its business. It has been widely accepted that involving patients and giving them support means that they recover quicker, and this is beneficial both for the patient and also eases pressure on the NHS. There is increasingly a trend towards regarding the patient as a customer. This is a positive development as it carries with it connotations of choice, satisfaction and rights. All of these are elements in their own way of empowerment. We often hear the term expert patient used. There are expert patients who are able to navigate the information processes and arm themselves with considerable knowledge with regards to their illness and treatment options. These people, however, are the minority. The vast majority of patients have to place themselves entirely in the hands of the healthcare system. NHS Choices was launched back in 2007 as a site where patients can get information on their condition and also compare hospitals on a range of different factors. For example, those patients for whom waiting time is a critical factor will be able to identify the most appropriate hospital, while others who may wish to base their decision on travelling times or incidence of MRSA will also have their preference met. However, patients made little use of available information on the performance of hospitals. Only 4% of patients consulted the NHS Choices website and 6% looked at leaflets, both of which provide comparative information on hospital performance. Instead, patients relied heavily on their own experience, 41%, that of patients and family 10%, or the advice of their GP 36%. It should not be forgotten that in 2010, 9.2 million adults have never accessed the internet and would therefore not be able to access this data in this format. Clearly, creating awareness amongst patients and giving them the ability to access this information is important. The White Paper pledges to institute an information revolution. In order for this to be effective, patients need to be aware that this information is out there and they need to know how to access it. Systems and processes must be in place, and essential basic information must be available for all in an easily accessible format. How this is to be achieved is still very short on detail.
Well, I'm a GP. For me, the choice agenda is misguided, it's misinterpreted, though I suspect it's well-meaning. I think, and I say this as a GP, that it risks driving a political wedge between that sacred relationship of the clinician with their patient. We now have a choice, or potentially have a choice, of doctors, GP, consortia, practice, hospital, or treatment. Collectively, GPs see about 1 million patients per day. And do you know what? The one thing patients, and I'm sorry to say this, do not come banging on our drum about is choice. They don't ask for choice. They do clearly, and some patients do, for very complicated, really quite complex acute processes. So, for example, the last patient that I sat down with, where we looked at choice, wanted a prophylactic bilateral mastectomy because she had a very, very strong family history of breast cancer. And clearly, she wanted to go to the place that did her reconstructive surgery that was as good as it can get, seeing as she was still in her 20s. But choice is not an issue for the sick. It's not an issue for those, for example, a mother with a Down syndrome child. It's not an issue with respect to the drug-using patient that I saw this morning. It's not an issue for my mother or my father with dementia. and is not an issue for the elderly person that falls outside and has a fractured neck or femur. It may well be an issue for the fit, the young and the wealthy, and I think they are driving this agenda. Can I just say, though, why I find this agenda rather patronising? Because as a doctor, I do offer choice. I offer choice within the consultation, within every consultation. And I offer that choice on the personal one-to-one level, or 1 to 2 if it's a mother with a child or a couple. And I offer that choice with information, with explanation and with engagement. Followed up perhaps with written information they can take away, and increasingly with websites, trusted websites that they can access to get more information. We doctors spend on average 12 years training. A training that allows us, I think, to make a judgment based on the best interest of the patient in front of us. When the patients are asked about choice, and they have been several times, actually what they say, they want a doctor they can trust, they want a doctor who cares, and they want a hospital with a car park. Right, let's move on to that dirty word, rationing, and the white paper. Choice in this cash-strapped NHS is nonsense. Commissioning decisions will be made on cost, hopefully on quality, but choice will be restricted, and believe me, it will be restricted. We're already restricting choice through referral management centres, through restricting choice to I've just picked up an email from a very senior colleague. I cannot refer to a named consultant at all, and that will become less and less. We will even have to restrict treatment because of the cost. Choice is the emperor's new clothes. It is a political mantra that has no substance. Branding patients as a consumer in the market of healthcare, I think, is dangerous and cruel. Finally, the idea that doctors are on their pedestals and patients are on their knees, which is what the Picker Institute said the other week, I think is unhelpful, and it certainly does not reflect the world that I live in or the world that I'm going to lead for the next 3 years. I think we've got to stop pretending that patients are consumers. Health care is not like buying cornflakes versus eggs for breakfast. If it were that easy, then we would just be accessing the supermarket through the internet rather than through your GP practice. I believe we should be offering patients the best that the health service can give. I think we do this through mutual respect and treating patients as partners in their illnesses and involving patients in every step of the way of their healthcare. Thank you very much.
I think there's a sort of times one fears almost deliberate misunderstanding of what is being talked about when we talk about choice and patients, because clearly nobody is suggesting that this is like trying to buy a packet of cornflakes. But if we take a real story and start applying those principles, so take a relative of mine. She's being treated at the moment for breast cancer, and she also has leukemia. Now, she is somebody who absolutely fits Clare's description. She does not want to make any decisions. She absolutely just wants to trust the doctor. But the first problem that arises is it's just not that simple. There are at least 6 people she speaks to on a regular basis: an oncologist, a breast surgeon, a plastic surgeon, a breast care nurse, a large range of doctors, and they just do not say the same thing. So to give you one example, after her operation, her oncologist put her back onto Herceptin. She went to see the surgeon. The surgeon said, "You're not going back on Herceptin. It will slow the wound healing process." So he took her off. She went back to see the oncologist. The oncologist said, "I don't care what the surgeon says. I don't tell the surgeon what to do. I'm putting you back on Herceptin." Now, at this point, there is no option to simply rely on the doctors, to trust what the doctors say. As she says, unfortunately, I do have to make this decision. And by maintaining the pretense that patients do not have to make decisions, that they can simply rely on the system, we take away the need to, we fail to recognise the need to support them making decisions, because every patient has to make decisions. I should point out, I'm just dealing here with, that's just dealing with the breast team, who are all supposedly working together as a team. In terms of getting that group to work with the leukemia doctors, she's the only person who coordinates all that. Second point, choice undermines trust. It's often said it drives a wedge between the patient and the doctor. Again, going back to the story I was telling you, originally they said we're going to do operate and then do chemotherapy, and then they changed their mind and said no, we're going to do the chemotherapy first and then we'll operate. And then the surgeon was really unclear. It was quite a complicated case. There's a lot of and first he said, well, look, I can do the operation. And then he went, actually, no, I'm not sure I can. Maybe we need to have a plastic surgeon as well. And then he went to see the plastic surgeon, came and said, no, I think it's going to be fine. You're just going to have the plastic surgeon. And she was there during all these conversations, and there were clearly decisions being made. But at no point was it explained to her how these decisions were being made, what the issues were. And this undermines trust. When you're being told by a surgeon, oh, I think I'm going to do that operation, but there's a bit of sort of sucking of teeth and going, well, it looks a bit complicated, and then told, well, maybe there needs to be two of us, and then told, oh, no, don't worry, just the plastic surgeon's going to do it on his own. It's understandable if patients start to be a bit worried about the fact they're not being involved in these decisions. And if we look at the survey evidence about our system compared to other systems internationally, we are the worst health system in all the comparable data for actually involving patients in their decision making. We also do not score well on patients trusting their doctors. These things are related. By not involving patients in decisions, we undermine trust. Then there's the issue that the patient doesn't know anything. They don't know enough to get involved in these decisions. Again, we continue to say patients don't. We refuse to recognise that they should be involved in decisions. Again, going back to the story I was telling you beforehand. During her chemotherapy, she has the first session of chemotherapy. She comes out, she starts to feel pretty unwell, calls the hospital, they send out a nurse. 48 hours later, the nurse takes her temperature, says you need to go back into hospital. She's got an infection, they give her antibiotics. Second time, the same thing happens, and she goes, well, look, I'm sure it's the same thing. And they go, yeah, but you're not a doctor. We're the doctors. Come into hospital. She goes into hospital. She stays overnight. Again, give her antibiotics. Third time it happens, she says, please, I'm not well. Can I not come into hospital? No, we're the doctors. Into hospital, given antibiotics. And on the fourth occasion, she finally said, look, I'm just not doing this anymore. I do know something about my situation. Please listen to me. And then was just given the antibiotics. There are many areas where we've just failed to recognise that patients really do not know what they're talking about. They are the only person who is involved all the way through this process. And when they talk, we do need to listen. I think we sometimes misunderstand what patients mean when we talk about patient choice. Clearly, they do need to be listened to, they need to be respected, they need to be given information, and if they wish to make choices, they must be allowed to make choices. Choices of where they are treated is essential. It's often said, well, if the whole system was great, you wouldn't need to do that. There's no health system anywhere in the world that with any amount of money in any organisation has delivered consistently high-quality care. We know care varies enormously and that there are gross failures of care in different situations. In that situation, it's completely unreasonable to suggest that patients should not be helped to make choices. And indeed, it is in fact a useful mechanism for trying to drive up standards. The last point I just wanted to make was this idea that it's just for the rich. I don't know why this keeps being perpetuated. Just look at the evidence. The surveys say repeatedly the desire to be engaged in decisions and to have choices applies across the board, and that where it has been exercised, it has benefited the less affluent more than the affluent. It's a system that pretends nobody gets choices, that it helps those who are pushier and who are more articulate. A system that recognises patients need to be empowered, that they need to be given choices. That is one that is fairer. Thank you.
I got a message a while ago in the surgery that a patient had phoned up and said he needed to speak to me urgently. Could I call him back as a matter of urgency? So in a gap between patients, I called him back. And I found him on his mobile phone sitting in the toilet of a private medical institution not very far from here, wanting to consult me on the advice he just received from a private orthopaedic specialist to have a major knee surgery. And he said to me, Doc, he says I should have this knee surgery. What do you think? Now that's an interesting situation into which we're pitched increasingly by the rise of that kind of medical treatment in the private sector. He's ringing me because a number of reasons. One is that there's an element that he's saying he trusts me because he knows me and he doesn't know the orthopaedic surgeon, but more importantly because he recognises that the surgeon has a financial stake in doing the surgery. And I haven't. So he thinks he's going to get independent advice from me on that basis. Of course, other people would say, as a doctor, and people often say you won't prescribe me these drugs because you're trying to save money on your budget, which is another, a financial incentive in the opposite direction. But he's also trying to close down the gap in information between himself and the surgeon, and the problem that's created by his sort of lack of security in the advice he's getting, by getting more information from me. What do you think? And he wants to know, is this the right operation? Is it the right bloke that's doing it? Is he any good? And is the hospital in which he's suggesting doing it, is that going to give him MRSA or some other lethal complication? And he wants to get my feeling on that. Well, the problem with that is I don't know much more than him about any of those questions. And I don't know the surgeon involved. And as Claire said, we're not allowed to refer to particular surgeons anymore anyway. And that old days where you did know and you could use that advice is no longer, even in the public sector. Is the hospital that he's in can it be trusted in terms of its infection control procedures and everything else? I don't know about that either. But it's in relation to exactly these sorts of uncertainties and the sort of problems that Roger and Katherine have brought up. People are very unhappy with the kind of care that they receive in all sorts of areas, not just in the public sector, but also in the private sector. They feel that they get a poor quality of treatment, medical treatment, and they, more importantly, often, and this is the point I think Katherine made, they feel they get a poor quality of care. Roger's website is a way of attempting to try and close down that knowledge gap, that you can find out some information. The trouble is that everybody in the real world knows you just cannot trust that information. It's a very interesting thing. If you ask teachers about, league tables in schools, they say, anybody knows they don't make any sense. If you ask teachers about what they think about league tables of hospitals, they somehow think that there's real information there, But it's the same thing, that these things are so easily figured. I don't believe for a minute these league tables that compare across countries about rates of survival, about anything. They're so easily manipulated, and the sort of advocacy research that goes into them, you can commission research to demonstrate what you want to do, and this is what's used in all these areas. And I think it's understandable that patients should want to get involved in all these kind of consultation things to try and improve the quality of their experience. Again, I have no sense that actually works. There have been measures to involve patients in both general practice and hospital care for many years, and they degenerate into token. They're so easily manipulated, they can be used in all sorts of ways. I'm afraid they just don't work. And then one of the problems with it is, and I think Clare alluded to this, is that being a patient is usually you're ill, and therefore you're not in a position to be making these demands. The very nature of the people who participate in these sort of forums is that they are not ill. So they're a very particular sort of patient. They are unrepresentative of patients, and actually they're not accountable to any collectivity of patients either, and they're in no way answerable to them for the sort of representations that they make. Roger says that that there's evidence that shows that people get what they want. Well, I think there's very strong evidence in the other direction. If you look at that, we've had 10 years of health policy encouraged by focus group. And one of the things about focus groups is you have to be pretty fit to be in a focus group. You have to be able to speak English to be in a focus group. You have to be in good mental health. You have to not have learning difficulties. You have to be not a child. You have to be not an elderly person. In other words, none of our patients are involved in focus groups, hardly. They're a tiny minority of the patients that we're seeing on a day-to-day basis, and that has led to the ascendancy of the interests of the worried well over the seriously ill in the health service. The idea that you can solve these problems because these problems are associated with the state provision of healthcare by the influx of the intrusion of the market has been the thing that we've had for the last 20 years in all sorts of different ways. But people should remember the state only got involved in the health service because of the failure of the market to provide it. That's why the National Health Service was set. The hospitals were nationalised in Britain because the hospitals couldn't cope with the pressure of war. And you only have to look at the hegemonic capitalist country in the world to see the United States, which has a very high quality of healthcare for a minority of the population, and an atrocious level of healthcare for a very significant minority and growing section of that society. It's not a very appealing model. The idea that the market can come to the rescue is very striking, what a lack of confidence there is in this, in the authorities who are trying to push it. This recent white paper, it's very interesting, sprang out within 6 weeks of the election, that it wasn't mentioned whatsoever, and you can only have to read it to say it wasn't written within 6 weeks of the election, been prepared for 5 years. Why didn't they have the bottle to put that before the electorate to say, well, is this the reform that you want in the health service? They're always saying, we are going to protect that there's going to be no payment at the point of use. Well, why? That's the cash nexus. That is about the market. If you want the market, well, people should pay cash on the nail for their medical consultations. That's what the market is. And so that they want the market, but they don't want the market in any kind of proper form for it. GP commissioning. What does it mean? Has anybody ever been to the corner shop and said, "Can you commission me a car? Commission me a washing machine?" What is it? It's a sort of an attempt to have the market without the market, and it does away with the whole ethos of public service that has indeed become exhausted and in the condition of the NHS as it exists now, doesn't provide a way forward. I'm not defending that old order of the NHS, but I think we have got to be careful about these things that are put forward as solutions which are more likely to make things worse. Final comment I would like to say is that I think we're asking the wrong question here. I don't know what the answer is to this problem, I should say, by the way. Although I'm very sympathetic with everything that Claire said about this, and particularly we don't want to do things that are going to make it worse. But I think we're asking the wrong question, because to me the question is not how can we turn patients into consumers, but how can we avoid turning every citizen into a patient?
I'm gathering from what has been said in challenging this is that it's a fairly patronising agenda that you're supporting. How would you respond to that?
The difficulties for patients day in, day out is that they are not engaged, they are not consulted, and Clare and Mike are probably the minority as opposed to the majority in the provision of healthcare. That the experiences that patients are faced with day in, day out is very, very different to what you have just described. It's very difficult for patients to feel there's a partnership. It's very difficult for patients to feel involved because very often they are at the mercy of the doctor. Now, there are a huge percentage of people that will be happy with that, but there are a certain amount of people that want more information so that they can actually make a decision about their care.
I think you're muddling the need for better doctors and better systems with the need for better choice. The systems to put in better choice will be expensive. They'll need to be updated. We had the nice debate. They'll have to be evidence-based. We'll have to have a whole industry creating choice, which will be outdated almost as soon as it's written. I don't live in the world where doctors patronise patients. I see patients every day, and I head up, or will head up, but have been vice chair of the college for the last 3 years and have 20 years experience. I don't live in that world. I suspect there are doctors, I'm sure all of you will tell me, who are patronising, but I see the world of general practice as one, and of hospital practice as one, of significant improvements. And I would actually say the example that you gave about the care of your niece being discussed with those consultants, I would have actually said, your patient, your niece shouldn't have been in the room, because they have to have those discussions. And what we've got through now is this ridiculous situation where we've got to have those discussions, some very serious discussions, where doctors don't know the answers, because believe it or not, medicine is still an art and is not a complete science. Well, we don't know the answer, and then present the choices. But because now the mantra is the patient has to be there for every single bit of that journey, where do you have those private conversations? And where do you have them in the language that the patient understands? Because then you dumb it all down, then you can't have a serious... Then we'll have to send everybody, all of you, off to evening class to learn the language, or we bring it down. So let's be clear. Whilst I am not in favour of doctors being patronising and rude and uncaring, I don't think the choice agenda and the millions of pounds that's spent on irrelevant information and choose and book... Has anybody been offered a choice through choose and book? Yeah, the millions of pounds spent, if not billions of pounds, is not going to answer that. I will change my profession if you give me the money that's currently tied up in all these agendas, and I will improve general practice, and I will make it better for patients.
The problem with that is that we know too often that healthcare systems fail. And the idea that, well, just give me the money and I'll make it perfect, that isn't going to happen, because it never happens. It hasn't happened anywhere. In that situation, we do have to look at the information. And what is worrying is the patients find it really hard to understand this information. Yeah. What they need is professionals who will look at it and help them, because the infection rate data does tell you that there are differences between your risk of infection between hospitals. The evidence that Basildon Hospital was in a lot of difficulty was very clear. The evidence that mid-staffs was having difficulties long before the inquiry was very clear. There were newspaper stories about Maidstone and Tunbridge Wells about the C. diff infection happening. And through all those periods, what did the local GPs do? Did anyone for a minute stop and say to one of their patients, hang on a minute, there is an awful lot of data that tells me that there may be some issues at this hospital. You might just want to think about, or even I might in private want to think about whether there's something else I should do with it. That never happened. The patients continued to be sent to those hospitals. No one used the data, even though the data proved to be absolutely correct about what was going on. And patients suffered as a result of that. And when we say, why does that happen? I mean, one of the issues is, how much does it matter what patients think about their doctors? How much does it really matter? And the moment in the system is not really that sensitive to what patients think about it. Doctors, I think often, this may be unfair, Clare, but there is a worry that doctors are more worried about what other doctors, for example, their colleagues in the hospital, think about their decisions than they do about what their patients think.
And Mike, can I just ask you, because it was implied that both you and Clare were maybe different, better because you're nice kind of doctors, as opposed to all those horrible ones that are out there. Do you think that there's a potential for choice to drive up standards?
I don't think Clare and I are particularly nice doctors. I think that we all operate within the structures of the health service as it exists, and that is a very much the culture that also exists, and we're very much driven actually by the demands of patients and by the culture that we live in. I don't think the choice agenda helps. And I think Roger confuses two different things here. I mean, one is that there are issues of poor performance of doctors and hospitals which need to be properly tackled. But that's confused with the idea that you can establish on the basis of league tables and differentials that enable patients to make informed decisions and choices about which is the best hospital to go to. I mean, that's a completely separate issue. And that's the idea that choose and book. I can sit down in my surgery and get up on the screen. Do you want to have your hernia repair in Scunthorpe or in the local hospital in Homerton? Well, what people want in Hackney is they want to be sure that they can get decent care in their own local hospital. They don't want to go to Scunthorpe or Canterbury or anywhere else, even if they've got that. I can scroll the whole list and look at the hospitals. What do you think, Doc? Would you go up to Scunthorpe for your hernia repair? I don't think so. It's not. No. So it's a farce. But there is but as Clare says, one of the things, there is a real improvement there because there is a rational part of choose and book, which is book, which is a computerised booking system when it works. But because of the IT scandals of the health service, it doesn't work half the time. But when it works, actually, it's really good because you can book an appointment. Brilliant. Choose doesn't help, doesn't provide better quality.
But talking about your patients at the Homerton, would you actually refer your patients to a ward on the Homerton if you know there was a dangerously high infection rates on that ward? Or would you actually refer your patient to a hospital of their choice because they were less likely to get an infection?
I would not trust the league table which said that there was a particular rate of infection on a particular ward in a particular hospital compared with another ward in another hospital. I wouldn't believe that.
But so how does a patient then?
They can't. That's the problem.
Okay.
They can't.
Right.
It's an illusion to think that you can make a choice on that kind of quality of information.
Can I just say, I'm actually only alive today because I found out about a treatment from a distance away from where I live, and thankfully my doctors listened to me. My background helped me to find that out, but had I not had that background, I wouldn't be here now. Now, to me, if this is going to be more sort of inculcated in the culture of the health service, then that will enable people who don't have my background to perhaps access that level of knowledge and perhaps have their lives saved.
I promise you, there is limited resources out there. I cannot refer you to anybody of your choice, so forget that as an agenda item. There is no choice left because already, as you've heard, we cannot refer to a named consultant. We very soon will not be able to refer you to a consultant. You'll have to go to a sort of holding clinic, a bit like when you go on skiing holidays and you go to a holding pen because you're not trusted to go into the proper airport. You'll go to a holding pen where you'll be seen and managed as a tier by somebody else who will then deem whether my competence is good enough to allow you to go and see a specialist. So let's be absolutely clear, patient groups and Dr. Foster, this isn't going in the direction of choice. So let's stop pretending that it is and start getting back to caring.
But when patients actually go and see their GP and they are being referred for a second opinion or referred because they have to have an operation, tis then for the patient, for their referral to be, as you referred to, in a holding pen, that's absolutely appalling. And I think patients actually need to know that information.
Well, it's in the King's Fund report about 3 weeks ago, referral management centres. It's not, no secrets, that's what's happening. You can't refer to a consultant psychiatrist, you haven't been able to for years.
The point about the spurious anti-elitism of all this, I think the great weasel words in this is empowerment. And it's the illusion of empowerment is what it actually provides. And there's an idea that this kind of does away with deference to the traditional doctor, the kind of old-fashioned Lancelot Sprat, which is an extinct species. And it actually tries to replace that with deference to some third party, some external source of authority, which is actually even more unreliable than the doctor in front of you, and it just defers the problem somewhere else. The second was the point about the burden it can impose on the patient, and this is the wider thing of informed consent to a greater. And what it comes down, I mean, the patient, I've had this phone call as well. Doc, he said, I need an operation. I had a woman who had she had a ruptured ligament on her knee. There was no way she could survive without having it. She couldn't walk without an operation. But she says, Doc, he says that the risks of operation include hemorrhage, infection, death from anaesthetic. What shall I do, you know? That's too much information that is at all useful to somebody. And what it's about is covering your back as a doctor. This is the whole thing, is that you've got to go through all this, ticking all these boxes. That's not conducive to good patient care, either in terms of the content of it or in terms of looking after people.
I think there is a difference, isn't there, between the complaints of patients who complain to the Patient Association being dealt with and, on the other hand, constructing an elaborate system of choice for which there's no evidence of it improving effectiveness. Similarly, within reason, there's an argument to make the health service more responsive so that you can get your appointment when you want without an elaborate market system of choice.
We are all effectively talking about partnership working, but what I'm suggesting is that the partnership working, where it's failing, is the patient isn't being given enough chance to question, to understand, and to, where they know something, where they do have something to contribute, to actually affect how the decisions are made. That's the case I'm making. So I'm recognising that there are many instances in which that won't be required, but there are many instances where it will help enormously, and there are. I was given an example recently about Crohn's disease, where there's a number of people who really do know a lot about their condition, and a patient who had come to the view that this was their condition, but it took 19 appointments before she finally got to see a doctor who said, yes, you're absolutely right. And what I'm trying to suggest is that the system does not listen. Doctors do not listen to patients. They do not use, often, the evidence that's available to them to advise patients about things that may be in their interest. And a simple example of that is if you look at almost any major operation, if you provide patients with more information about that operation, fewer of them choose to have the operation. If you just leave it to the doctor, more of them have the operation than patients would choose if they're given the information themselves. So that tells you that not involving the patient in these decisions, that A, it tells you that we're not involving them enough, and B, it tells you that if you do involve them, it does affect the decisions that are made.
Actually, how many people know of somebody with dementia who's had a positive experience of going through an acute ward in a hospital? We all know that there are cultural problems. The issue is, however, how you solve them. And it isn't through choice, it isn't through marketisation, because in my experience that leads to more and more fragmentation, and that actually is the problem.
My concern is this idea of patient choice being placed over other things, by efficacy of treatments, and the deferral of responsibility, particularly with relationship to politicians. And we've been talking about the patient choice agenda, and I think there's a bit of a danger of patient choice becoming a bit of a crutch and something behind which politicians hide. For example, in the Response to the Science and Technology Committee report on homeopathy, Andrew Lansley put patient choice above everything else, and I wonder whether there's a danger of this being a real problem.
Yes, well, there's a sort of theme here that worry that choice is going to shift responsibility onto the patient and undermine trust. And clearly it's possible. It's possible if you do it really, really badly. If you turn around to the patient and say, here's the information, you make the decision. Yeah. But that isn't what we're talking about. And it isn't about, we keep referring to the market, this isn't about having a market. This is about engaging the patient, enabling them to be involved in decisions to the degree that they want to, and supporting them to do that. And more importantly, the patient is looking to often the GP to act on their behalf and be their advocate. So where there is a decision to be made, to trying to make that decision in the best interest of the patient. And that might involve actually deciding that a service at a local hospital is simply not good enough. And there is very strong evidence that occurs often, and that GPs ignore this. So we're not talking about a situation of trying to make lives harder for patients. We're talking about trying to adapt the system in order to make life better for patients and to improve the quality. I thought the point at the end here is it's given too much emphasis? Is it a sound point, if you know what I mean? But I think it's slightly missing the point. I don't think we have a choice between having a great health service and having patients who are given the degree of control they want over their healthcare. I don't think you just can't have a good healthcare system unless you do that.
Well, you can't have a good healthcare system either if you establish the notion of consumer sovereignty as the dominant principle. And I think this is the danger that we've got. One of the great doctrines of the market is the customer is always right. Well, one of the problems that we face every day as GPs is actually the customer is quite often wrong. And one of our responsibilities as doctors is to try and get that across to people. people who often think themselves to be the best informed make often very bad choices, and we spend a lot of our time trying to discourage them from making such choices and trying to alleviate the consequences of them. So I think these are the dangers that lie in their promoting the ascendancy of this agenda over everything else, and it can prove a very destructive one for doctor-patient relationship, but ultimately for the welfare of patients.